I recently spoke with Michael Dinneen, MD, PhD, and Director of the Office of Strategy Management for the U.S. Military Health System, although we spoke about a new type of civilian health system called an Accountable Care Organization, or ACO. Dr. Dinneen previously served as Director of Medical Services at the National Naval Medical Center in Bethesda, Maryland. A psychiatrist by training, he also served as a special psychiatric consultant to the Secret Service and the State Department, and he also has special expertise in military psychiatry acquired during the Desert Shield and Desert Storm campaigns. We've broken the interview into two parts. This will be part one of my interview with Michael Dinneen. Let's roll that tape. What exactly is an accountable care organization? What's the purpose of that type of organization?
Well, the purpose of the organization is to be accountable for something. And in the military health system, we've said that we want to be accountable simultaneously to have people ready to face the challenges they may face in health, whether they be infections or accidents or those kinds of things. We want to be able to say that we're accountable for improving the health of a population that we serve. That's number two.
When you say accountable, accountable to whom?
It's a great question. In the military health system, we're accountable first to the Secretary of Defense, but really we're accountable to the American people. They're the ones that pay the bills. But more importantly, we're accountable to each and every patient to be sure that they feel like when they come for care that they'll get something that's of very high quality and that won't harm them. And that's the third component. Beyond readiness and population health, it's an experience of care. We're accountable to the patient to provide an experience of care that's safe and effective and efficient, and that makes them feel like someone actually puts them at the center. And then finally, as Secretary Gates says, the cost of healthcare in this country is unsustainable. So we have to be accountable for being good stewards of the government's money, or of the taxpayers' money.
Well, is there a problem with the way health care is delivered now? Usually an organization is designed to solve a problem. So what's wrong with the system now that it needs a new organization?
Well, there are basically two problems from our perspective. One problem is that we pay for the wrong things. Right now, in this country, we pay for volume. So we have a fee-for-service model. So the more that is done for a person, the more the providers or the doctors and the hospitals get paid. So that essentially provides a tremendous incentive to provide lots and lots of services, and that's one of the things and especially use lots and lots of technology, and that tends to drive costs up. The lower cost interventions like coordinating care, doing education, helping with nutrition, those aren't actually even paid for in the current system. So one of the problems that needs to be fixed is the lack of incentives for health. We now have incentives for sickness, and so that's one thing that has to be fixed.
So what would this type of organization look like? Who would its members be? Right. Would it be a hierarchical organization where somebody in the organization decides what treatment you're allowed to get or what tests you're allowed to get?
Well, actually what it would be best based on is the best evidence that's out there, and this is where we really want to leverage technology so that doctors at the time that they're seeing a patient will actually have access to decision support, so that they can say for a diabetic, gee, you haven't had your blood pressure in control, or you need to have better control of your cholesterol, or we need to be taking care of your kidney. And that would be supplied by a very powerful electronic health record. The other thing that technology would help us with is connecting the dots between what just happened at a hospital and then what's happening when the person comes back to their primary care doctor. And that's not happening frequently now.
So you're talking like something like a national healthcare database where your entire medical records are all stored in cyberspace and any doctor who treats you has instant access?
That would be the long-term vision, that's done and in a very safe way, so it doesn't lead to problems with privacy, invasions of privacy and such. Probably the best example of electronic health records that are working now are in our system, in the military health system, the Department of Veterans Affairs, and Kaiser Permanente. But Kaiser Permanente has done particularly well in that what they have is a single electronic health record where not only do the doctors have access to all the information, but the patients themselves do. And the patients now are able to see what's gone on every time they've touched the Kaiser system, so that they can take personal charge of their own health. And I think that's where the real advantage is a truly accountable care organization will be accountable in real time to the patient, so that they get their lab results right back. They know how well their system is doing in treating the illness that they have.
So that was part one of my interview with Michael Dinneen. Now he's talking about following a patient as he goes from one place to another. Now, is that compatible with what you're doing at PAMF? You might have a patient who is treated at PMF some of the time, but sometimes they have to go to Stanford Hospital, sometimes they go to UCSF. Once a person is outside of PAMF, can you still track them, or do you plan to do so in the future?
Yes, we do. Today, that's somewhat problematic. It's not as good as we'd like it to be. To get information when our patients go to Stanford requires some effort to get the information back. It shouldn't be like that. It should be seamless to be able to know what's happening with the patients in the hospital admission and on their discharge. And likewise, when individuals go in for an admission, the doctors in the hospital should be able to get access to the information from the primary care environment, because the benefits of that are huge, avoiding duplicating tests that have recently been done and just keeping the care coordinated. So that is a direction we're moving in very fast. He's talking about accredited care organizations that are a driver for this. It's a very positive move. Right now, this model is being experimented with. It's being tested. If it works, it could be a direction of travel for a large part of the sector, the health sector, the way we move and the way we deliver care. The jury's out at the moment, frankly. It's somewhat of an experimentation. Although I have to say, people believe that this is a direction we're all going to move in. It makes a lot of sense that we coordinate what we're doing with our patients and provide a better experience.
Well, is this related to social networking? You have things like Facebook where information can be posted and anybody can see it. Is it basically resting on something similar to social networking technology?
Not really. Social networking, I think, is an increasingly important part of what is provided for patients. If we think of social networking, it's the interaction with other people who may share similar experiences or conditions. That's an important way of learning and improving what you're doing. But as I think we all know, those social networks tend to be open. Information tends to be shared without too much regard for privacy. And we've got a big responsibility with information that's provided in the context of delivery of care that requires protection. So the two are similar, if you will, but they're not the same thing, and we shouldn't confuse one with the other.
We're going to go on to the next segment, which is part two of my interview with Michael Dinneen, and then we'll come back and speak for a few more minutes with Martin Entwistle. So let's go ahead and roll part two of that interview.